In this last lecture on the endocrine system, we're going to talk about the pancreas, we're going to talk about stress and the stress response, and we'll talk about a few other miscellaneous hormones as well. This material once again comes from Chapter 16 in Marib. Let's begin by talking about the endocrine pancreas. Remember, we talked about the digestive function of the pancreas in terms of the enzymes that it secretes. Now what we want to do is talk about the endocrine pancreas. And if you look down in this diagram on the bottom, you'll see this small section of the pancreas that's known as an islet, sometimes called an islet of Langerhans. This contains cells that secrete hormones directly into the blood, so this would be the endocrine portion of the pancreas. And you can see a light micrograph of this section of the pancreas as well, with the islets being the lighter staining cells here, the enzyme secreting cells being the darker ones that you see here. Now, in terms of what the endocrine pancreas secretes, the two major hormones that we're going to be concerned with are glucagon and insulin. It does secrete a few other things, including somatostatin, which we've talked about earlier, as well as something called pancreatic polypeptide. We're going to really focus our attention primarily on glucagon and insulin. Glucagon is secreted by the alpha cells of the pancreas, while insulin is secreted by the beta cells. Let's take a look at what each of these hormones does. Let's talk first about insulin. Insulin decreases blood glucose levels by allowing cells to take up glucose from the blood. Now, the tissues that use insulin to take up glucose from the blood are known as insulin-dependent tissues. There are a few insulin-independent tissues that include the brain, kidneys, liver, red blood cells. These are tissues that don't rely on the hormone insulin in order for glucose uptake to be accomplished. However, other tissues like skeletal muscle require the presence of insulin in order to take up the glucose from the blood. So let's take a look at how insulin functions in glucose homeostasis. In this diagram first, you'll notice at the bottom that the normal concentrations of blood glucose in the plasma are about 70 to 110 milligrams per deciliter fasting. So between meals, this is about the level of glucose concentration we should have in the blood. And if you remember, we talked about before the fact that a deciliter is equal to 100 milliliters. So we could say that the normal glucose levels are 70 to 100 milligrams per deciliter, or 70 to 100 milligrams per 100 milliliters. Now, in this diagram, what we have is a situation where blood glucose levels are rising. For example, after we've just eaten, especially after we've eaten a carbohydrate-rich meal. That's a signal for the beta cells in the pancreas to secrete insulin. And we talked about insulin earlier when we discussed metabolism and the fed state, but all of these functions that you see here are functions of the hormone insulin. If you remember, its primary effect in the body is to work as a storage hormone. So this promotes storage of materials into body cells when they're plentiful, for example, after we've eaten. Let's take a look at some of these. We have an increased rate of glucose transport into target cells. This is a direct effect of insulin in those target tissues that we talked about earlier. We also increase the rate of glucose utilization for energy, and that is creation of ATP. Increase the conversion of glucose into glycogen, especially, for example, in liver and skeletal muscle. You remember this is the process of glycogenesis, making new glycogen. Increasing amino acid absorption and protein synthesis. So once again, we're in the storage mode. And finally, increased triglyceride synthesis in adipose tissue. Remember, this is lipogenesis. So all of these promote storage of materials that we've eaten. And what this does is decrease blood glucose levels by moving the glucose from the plasma into the cells in the body. After these things are accomplished, the blood glucose concentration declines, and we have a restoration of homeostasis, bringing blood levels back to around 70 to 100 milligrams per deciliter again. Insulin release is also affected by the autonomic nervous system, in particular the sympathetic nervous system. Shouldn't really surprise you, because during the sympathetic nervous system, which is our fight or flight nervous system, we need increased levels of glucose throughout the body in order to power all the tissues that need to respond to the emergency situation or the situations that bring about sympathetic stimulation. Here you'll see a homeostatic diagram of glucose metabolism. Once again, we're targeting this homeostatic range of glucose, 70 to 100 milligrams per deciliter. Here we would have a declining level of glucose in the blood, present, for example, during starvation or between meals. What that does is to prompt the alpha cells of the pancreas to secrete glucagon, and that results in the activities that you see here. So glucagon, if you remember, was one of the hormones that we looked at earlier when we talked about metabolism that promoted withdrawal of things from the tissues to make new glucose for the body. Some of the things that are accomplished here, you'll see increased breakdown of glycogen to glucose, especially in the liver and skeletal muscle. This, remember, is glycogenolysis. We also have an increased breakdown of fats to fatty acids in the process of lipolysis. And the fatty acids can then be used by certain tissues in the body in place of glucose. That will keep the glucose that's in the body available for those tissues that specifically need glucose, for example, the brain. Remember, we referred to that before as a glucose sparing effect. And finally, we have an increased synthesis and release of glucose in the liver. This is the process of gluconeogenesis. So the liver makes glucose from things like lactic acid, oxaloacetate, pyruvic acid. All of those are part of gluconeogenesis. After these are carried out, we bring up the blood glucose concentration, and that's going to eventually restore homeostasis and bring us back within a homeostatic range, as you see over here. This is an overview, a big picture of insulin and glucagon action in the body. This really is a summary of the previous two slides that we've seen, but in one place. So this is a good big picture summary. The other thing I want to mention is that when we talk about insulin and glucagon secretion, we are talking about a humoral stimulus for hormone secretion. Remember, we defined a humoral stimulus as hormone secretion being controlled by something that is not a hormone. In this case, we're looking at levels of glucose in the plasma, which is not a hormone, causing the increased secretion of hormones from the pancreas. That would be insulin and glucagon. Now, I'm not going to spend too long on this and not really hold you responsible for this, but this is sort of interesting. In the area of the brain that we have here and here, remember that we called this the diencephalon. Here we had the thalamus, here we had the hypothalamus. There's one more portion that's considered a part of the diencephalon, and that's right here. And that is the pineal gland or pineal body, which is sometimes known as the epithalamus. And what the pineal gland does, as you see on the bottom, is to synthesize melatonin from the neurotransmitter serotonin. Let's take a brief look at what melatonin does in the body. Melatonin has several different effects in the body, one of which is to regulate our day-night sleep cycles. And this is called a circadian rhythm. If you remember, we mentioned this before. These are daily changes in a physiological process that follow some regular pattern, typically time of day. So melatonin is an example of this. And when there's an excess light in the eyes, in other words, when we have our eyes open and it's daylight outside, what that does is decrease concentrations of melatonin. And it does this through this complex pathway. Light goes to the retina, to the hypothalamus, to the reticular formation, spinal cord, sympathetic fibers, finally to the pineal, which inhibits the synthesis of melatonin. During the time when we have a decreased amount of light coming into the eyes, for example at night, what happens is we have an increased concentration of melatonin. And what melatonin does is stimulate sleep. Now there's a couple of other hypothesized roles for melatonin. It may control the onset of puberty. There's a correlation between declining melatonin levels and puberty, so they think that there may be some role for melatonin in controlling the onset. It also helps to regulate the female reproductive cycle. And finally, it's a very good antioxidant and may protect the central nervous system against free radical attack. Let's talk a little bit about the reproductive glands. I'm not going to spend a great deal of time on here. The only thing that I want to hold you responsible for this portion of the course with regards to the reproductive organs are these. We called the ovaries and the testes, if you remember earlier, we called these gonads. And these are the primary sex organs, so ovaries in females, testes in males. The ovaries secrete estrogen and progesterone. The testes primarily secrete testosterone. And that's the extent of what I want you to know for this lecture exam on the endocrine organs. We're going to go much more in detail into the reproductive structures and glands when we talk about the reproductive system at the end of the course. The thymus gland we spoke about when we talked about the lymphatic system and immunity. In addition to the other things it does to help T lymphocytes mature, it also secretes thymosins, which are hormones. And these also aid in the maturation of T lymphocytes. Now, one additional substance I want to talk about is secreted by the heart. These are called natriuretic peptides. These include something called atrial natriuretic peptide, as well as another called B-type natriuretic peptide. Sometimes this is also called brain natriuretic peptide, depending on the source you're reading. What natri means is sodium. Remember, if we use this chemical symbol Na for sodium, this comes from the Latin name for sodium natrium. Uretic means in the urine. So literally, natriuretic means to put sodium in the urine. And as we spoke about earlier, if we move sodium someplace, water follows along by osmosis. So if we put more sodium into the urine, that means we're also going to be putting more water into the urine, and so we're going to lose sodium and water at the kidney, and this is basically going to lower levels of water in the body. So what this is essentially going to do, since it's going to decrease blood volume, is to decrease blood pressure. Not surprisingly, the stimulus for the secretion of natriuretic peptides is when the atria and ventricles are stretched. For example, when we have an increased amount of sodium and water in the body, this will cause plasma volume expansion, and that expansion will increase blood pressure, and that's a signal basically to the heart to secrete ANP and BNP, and this will lower the amount of water that we have in the plasma, and that will tend to return blood pressure to its normal levels. Now, ANP and BNP inhibit renin release, and they also inhibit the release of aldosterone. If you remember, we talked about the renin-angiotensin-aldosterone pathway, and that system was designed to increase reabsorption of sodium and water at the kidney, thus increasing plasma volume. So ANP and BNP inhibit this. These hormones also inhibit the secretion of ADH, the posterior pituitary hormone antidiuretic hormone that brings water back into the body. So this will also allow more water to escape from the body. Now I want to talk about something that's very important and how the endocrine system helps us deal with this, that is stress. When we talk about stress, we talk about two different kinds of stress: physical stress, psychological stress. This is the type of stress that you're naturally under because you're taking anatomy and physiology. So this is an emotional kind of stress. The other kind of stress, though, is physical stress. This can result from trauma, injury, surgery, and in terms of how the body reacts to these stressors, it knows no difference between physical and psychological stress. It reacts to both of these identically. So we can say that stress is any condition, physical or emotional, that threatens homeostasis. And the way we deal with stress is something that's known as the General Adaptation Syndrome, or what we term GAS. The heart of this response is at the hypothalamus, as we'll see in a couple of seconds. And what the hypothalamus does is it will trigger different things to be released, primarily epinephrine in one phase and cortisol and glucocorticoids in the next phase. And we want to take a look at these. The response to stress is easily remembered by this mnemonic ARE. We have 3 stages or phases to the GAS, or General Adaptation Syndrome. We have the alarm phase, we have the resistance phase, and finally we have the exhaustion phase if this goes on long enough. Let's talk about each of these in turn. You'll see a general outline here of our response to stress. And you'll notice the stress comes from changes in the external environment. Now, as we said before, this can be psychological or physiological. This will stimulate the hypothalamus to activate the sympathetic nervous system. One of the things that happens, of course, is we have norepinephrine released by the sympathetic response. The sympathetic impulses can also cause the adrenal medulla to secrete epinephrine and norepinephrine, as we said before. Remember, the medulla of the adrenal gland is basically a postganglionic sympathetic neuron, or set of neurons. So these will release epinephrine and norepinephrine. And the fight or flight or alarm stage that we have here is designed to help the body meet its emergency situation by releasing all of these things and causing all these things to occur. Increased glucose concentration, increased blood glycerol and fatty acids, so that tissues like muscle that can use fatty acids in place of glucose can do that. The glucose is preserved for the brain. Heart rate increases, blood pressure rises, breathing rate increases, air passages get bigger, they dilate. Pupils dilate so that we can take in more light and see what's going on. Blood flow redistributes. If you remember, we basically turn off blood flow to the intestines, the urinary system, the reproductive organs during the sympathetic response. So all of this is designed to help us meet what we term the alarm stage of our stress response. Now, if this goes on longer, and this is a chronic type stress, we go into what we call the resistance stage. And in the resistance stage, we have the hypothalamus signaling corticotropin releasing hormone to be released. That causes ACTH to be released from the anterior pituitary, and that in turn causes glucocorticoids to be released from the adrenal cortex. In particular, we're looking at cortisol here. And what this does is this is designed to increase blood glucose concentrations to allow those body tissues that need it to react to this chronic stress. So we increase the blood concentrations of amino acids, and as you remember, we can actually use these amino acids for energy. Increase the release of fatty acids, increase glucose formed from non-carbohydrates, like amino acids, like glycerol, like lactic acid, like oxaloacetate. All of these things serve to increase blood glucose. So this has somewhat of the same effect as the alarm stage, except this happens over a longer period of time. the amount of epinephrine and norepinephrine stored in the adrenal medulla is small compared to the amount of cortisol that can be released by the adrenal cortex. So one of the things I want you to note here is we call this first stage the alarm stage. The second stage is called the resistance stage. So this is the AR and ARE that we talked about. The other thing I want you to notice is that this stage is carried out by the adrenal medulla. This stage is carried out by the adrenal cortex and the release of glucocorticoids. So what happens if this goes on even longer? Well, what happens is we go into the stage that we call exhaustion. Remember when we first introduced the adrenals, I mentioned that their yellow color was due to the storage of cholesterol and some other lipids that are used to produce the adrenocorticosteroids. There's a finite supply of these lipids in the adrenal cortex, so eventually what happens is we decrease the lipid reserves and decrease the ability to make both glucocorticoids as well as those hormones that control electrolyte balance like aldosterone. Remember, aldosterone is a hormone that increases sodium and water reabsorption. Because of the deficiency of these hormones, what happens is we wind up with some damage to some vital organs in the body. And in fact, if this goes on long enough, the endpoint for this is death. Now I want to talk about some growth hormone abnormalities. And once again, the reason I talk about these abnormalities is not to really have you understand and know the pathology so much as to illustrate some of the physiology we're talking about with regards to hormones. So let's just talk about the few abnormalities that we have with growth hormone. This first one, called gigantism, results from hypersecretion of growth hormone in children. And if you remember, in children that are prepubescent, before puberty, we have epiphyseal plates in the bones. And the growth hormone will stimulate epiphyseal plates to expand and cause the child to grow taller, the fingers to grow longer, long bones to grow longer. Those are all the functions of epiphyseal plates that we talked about in Anatomy and Physiology 1. I think you can imagine that if we have a hypersecretion of growth hormone in children, they'll be much taller than normal, the fingers and arms will be longer than normal, and we actually have some other defects that can arise if the hypersecretion of growth hormone is severe in children. This is known as gigantism. Now we can also have hypersecretion of growth hormone in adults, that is, people who have passed puberty, and this is known as acromegaly. If you look at the diagram on the bottom, you'll see this young girl, age 9, that's pretty much normal. Following puberty, there was an excess of growth hormone secreted, and from age 16 to 52, you can see the progression in the facial features here. At age 52, you'll note the very square, large jaw, some of the typical facial features that we see with acromegaly, these large hands. And so what hypersecretion of growth hormone in adults does is to actually cause a thickening of the bones. They certainly can't grow any more in length, remember, because the epiphyseal plates have closed once the child gets past puberty. And then we have a deficiency or hyposecretion of growth hormone in children that can occur, and this can give rise to something that we call dwarfism or pituitary dwarfism. Essentially, if there's not enough growth hormone to stimulate the epiphyseal plates to expand adequately, the child remains small. However, there'll be all normal proportions of arms to legs to body to trunk. And so pituitary dwarfism leads to smaller stature, but all the proportions of the child are normal. A couple of more pathological conditions I want to use to illustrate some of the things we've already talked about. I want to talk about a couple of conditions, two of which are called diabetes. One is called renal glycosuria. Let's first turn our attention to the one up on top, which is diabetes mellitus. Diabetes means literally siphon or overflow. Mellitus means honey or sweet. So literally, diabetes mellitus is an overflow of sweet smelling or sweet tasting, I'll talk about that in a little bit, urine. And this can result from the hyposecretion or hypoactivity of insulin. Remember, the primary job of insulin in the body is to decrease blood glucose concentration in the plasma. And when we have a hyposecretion of insulin, that is when we don't have enough insulin or when the insulin is not as active as it should be, there's an elevated level of glucose in the plasma. However, the cells that require insulin to bring in the glucose can't use that glucose. So in essence, the cells are starving even though glucose is plentiful outside the cells. This gives rise to a few signs and symptoms of diabetes mellitus that we refer to as the 3 Ps. We have polyuria, which is an increased urination. So because we put something like glucose in the urine, which is a solute, water follows that solute. When we put more glucose in the urine, we also attract and hold more water, and so there's more water excreted in the urine that leads to an increased urination, which is the diabetes part of the name. This increased urination and loss of water leads to increased thirst, which we call polydipsia. And finally, we have polyphagia. This is an increased hunger body-wide, but also, remember, of the cells in particular that can't use the insulin to import the glucose from the plasma. So these cells are literally starving because they don't have the glucose that they need to metabolize. Some of the other things that we see are hyperglycemia, as you would imagine. The emia portion of this refers to in the blood. Hyper, above, glyce refers to glucose. So we're talking about an elevated level of glucose in the blood. We also see glycosuria, which is the presence of glucose in the urine. We'll talk about this with the urinary system, but literally, urine spills over from the plasma into the urine and comes out of the body. And so we can actually detect this, for example, with clinisticks or dipsticks. The last thing that we can see is ketonuria. This is the presence of ketones in the urine. Now let me just remind you of something that we talked about earlier. Remember, we said that when we had a decreased level of glucose in the body, what would happen is oxaloacetate, which is one of the substrates for gluconeogenesis, this can be converted into glucose. The only problem with that is when we take the oxaloacetate away from here, we don't have anything for the acetyl-CoA to merge with to go into the citric acid cycle. And so the acetyl-CoA is basically funneled back to the acetyl groups and goes to make ketone bodies, as we spoke about before. And these include hydroxybutyric acid, acetoacetic acid, acetone. Because the cells of someone who's diabetic or who can't use insulin relies more now on fatty acids, the fatty acids are increased, beta oxidation is carried out, we increase the production of acetyl groups. However, these acetyl groups can't go into the citric acid cycle because we don't have enough oxaloacetic acid. And so we have these funneled into making ketone bodies. And this is what leads to the ketonuria, or the presence of ketones in the urine in people with diabetes mellitus. The second kind of diabetes that we want to talk about is called diabetes insipidus. The second word in this means tasteless. There's an anecdotal story, and I don't know how true this is, that before we actually had sophisticated tests, people used to tell whether or not a person had diabetes mellitus or diabetes insipidus by tasting the urine. And if the urine tasted sweet, it was diabetes mellitus. If somebody was urinating quite a bit but was thirsty, but the urine didn't taste sweet, it was considered diabetes insipidus. And diabetes insipidus results from a hyposecretion or hypoactivity of ADH, posterior pituitary hormone, antidiuretic hormone, that causes us to conserve body water. So when we have a hyposecretion or hypoactivity of this, there's an excess of water loss from the body. Not surprisingly, we have polyuria and polydipsia. One of the things that we don't have in diabetes insipidus is any problem with glucose metabolism at all. So there's no elevated levels of glucose in the blood. There's no spilling over of glucose into the urine. There's no ketonuria. So there are some symptoms that someone will have with diabetes mellitus that they won't have with diabetes insipidus. And finally, the last disorder that we want to talk about here is renal glycosuria. This is a genetic disorder where the kidney cells are unable to reabsorb glucose from the filtrate in the urine, so the glucose once again spills out into the urine. So what we would see in somebody with renal glycosuria is we would see glucose in the urine. However, what we would not see is ketonuria, because there's no problem at all with normal glucose metabolism in these people. There's no elevated blood glucose levels, so there's no hyperglycemia. However, they would probably have these symptoms here. Because remember, if we're putting more glucose in the urine, that's attracting and holding more water, so we would have polyuria and polydipsia. However, we wouldn't have any polyphagia or ketonuria or hyperglycemia. So what I was trying to illustrate by showing you these three disorders is that you can have the same symptoms occurring, and a patient may come in and say, I've been urinating a lot, I've been very, very thirsty, and the first thing you might want to jump at is diabetes mellitus. However, it might not be that. What you would have to do is further characterize, for example, blood sugar levels, do a clinistic or dipstick on the urine to see if there's a presence of any glucose in the urine, also see if there's any ketones in the urine. So you'd actually have to do a follow-up based on these two initial symptoms of polyuria and polydipsia to differentiate between these three different disorders. Finally, I just want to show you the two hormone summary tables that we've already talked about. This one I showed you earlier. This has to do with the anterior and posterior pituitary hormones. So we went through this table before. The second hormone summary table that I have here is also important for you to know. Once again, what I tried to do to make this just a little bit easier for you, because I realize this is a lot of information to remember, is to summarize all the hormones, the tissues where they originate, the tissues where they're going, their action on the target tissues, and also, very importantly, the control of the release. How is the release of these individual hormones controlled? So the tables, I would say, between table 1 and table 2 probably contain about 80% of the information that you're going to need to know and memorize for the exam. I know this is a lot of information. The endocrine system is pretty extensive, but this is important information because the endocrine system is such an important control system of the body. Okay, so that finishes off our lectures on the endocrine system. Next up, we're going to begin talking about the urinary system, and I'll see you there for lecture 15.